Good day. My name is Benjamin. I'm from Costa Rica. I'm a dermatologist, a general dermatologist, but I had the opportunity to work at a children's hospital. And I also worked for the University of Costa Rica and the University Latina of Costa Rica. So we're going to review today pediatric psoriasis. And these are my conflict of interest, none which have to do with the talk I'm going to give about. And the objectives are this, although we're going to try to summarize it more because we only have 10 minutes. So it's a common immune-mediated systemic disease. It's about 0.5 to 0.8% of pediatric patients that come with this disease. You can see the child on your right-hand side, which by way of explanation, I have the permission of the parents for the pictures in all the subjects. It has a linear increase in prevalence, about 0.2% at 2 years to 1.2% to 18 years. It rarely presents at birth. 1/3 of adults had psoriasis from childhood. It is more frequent in white children. It can be from a life-threatening or neonatal pustular or exfoliative dermatosis to a mild localized disorder, which basically causes no distress in the children or parents. It has an irregular chronic course, remissions and exacerbations, negatively impacts quality of life for the family. So it is a very important disease. We can see there's genetic environmental factors. Usually there's a family history of about 30 to 49% of pediatric patients. Risk of monozygotic twins, 2/3 the times of dizygotic twins. We have certain locus, source 1, 35 to 50% of patients. MHC located to chromosome 6. HLA-CW6 early onset, and 73.7% in guttate psoriasis. We also have what's known as CARD14 mutations, CAPE or AKIDS, which is considered another disease. Deficiency of IL-36 receptor antagonist, DITRA, associated guttate pustular psoriasis. And we have, pustular psoriasis. We have a 64 susceptibility, loci for psoriasis, located to the T cell function, IL-23, TNF-alpha, which also explains response to certain drugs. Pathophysiology, it's a Th12 IL-23 pathway-mediated disorder. We have CD45RO positive memory effector T cells, which migrate into the skin by antigenic trigger, which is still unknown. Innate immune system. We also have Toll receptors, Toll-like receptors, mediate activation of plasmacytoid dendritic cells through AMP. There's skin injury, streptococcal infection, Staphylococcus aureus, Kawasaki disease, growth hormone, interferon, lithium, beta blockers, antimalarial, several triggers involved in the development of the disease. Plaque psoriasis is the most common clinical type and accounts for 41% of psoriasis cases in children between the ages of 2 and 13. And adolescents between 13 years old and older. Cardiac plaque psoriasis occurs in about 75% of children with psoriasis. It is characterized by well-defined erythematous plaques covered with mesenchymal scales. Facial psoriasis is very important. It's a good way to diagnose early psoriasis in children. More common in children than adults, and it affects 4 to 5% of the children in the face solely. So as you can see, the lesions here on your right-hand side, fine scales or thicker scales around the eyes. Sometimes we could be diagnosing facial contact dermatitis, and it is psoriasis, but we have to search for the scalp and other areas which can also be affected. So periorbital area, it is different from atopic dermatitis. It's more delineated, less periodic and an annular configuration, as you can see in the picture of the boy on the right-hand side. 5% of patients with psoriasis, eczema overlap, nummular and psoriatic form. There's a family history for both. Geographic tongue, also associated, and generalized pustular psoriasis and IL-36 and mutations can be seen. Guttate psoriasis accounts for 15 to 30% of cases of pediatric psoriasis, so it's very common, more common in children than adults, characterized by rapid onset of guttate papular lesions associated with infection. Scalp psoriasis, you can see this cute little toddler here on the scalp, common 20 to 50% initial lesion site is the scalp, characterized by well-demarcated erythematous plaques with superimposed silver scales. So you can see, you can have a differential diagnosis also with atopic dermatitis, but we don't have the cheeks covered here. So it is important to see, and you can see also affecting the eyes. Now going back and emphasizing it both, 44% of patients do glutate psoriasis as a first manifestation. Drop-like lesions, round oval, 2 to 6 millimeters, symmetric trunk and proximal extremities, often triggered by group A streptococci. And we can find also associated with urinary tract infections. 40% progress to more severe plaque psoriasis in other patients. Scalp, 20 to 40%. Again, more girls. Has been questioned if it's associated with calming. Thicker during silver scales, greasy, salmon colored, and a differential would be seborrheic dermatitis. Also, pityriasis amantiacea, asbestos-like, it's sore variant. 15% develop psoriasis. Diaper psoriasis, you can see, sorry here for the shade, but you can see how it spares the side where the diaper area, and then the trunk is also affected. But here the diaper is very much affected. Great differential for atopic dermatitis and other conditions such as seborrheic dermatitis. Most common type accounts for 37% of cases in infants with psoriasis. It exhibits as a well-defined florid and occasionally eroded plaque. So you can see here affection of the diaper area. Nail psoriasis occurs in about 40% of children with severe psoriasis. It is less common in children and adults, though, characterized by yellow subungual plates, oil spots, as you can see here in the picture to your right-hand side, these little oil spots, and pitting in the nail plate. You can see it back here starting little pits. Inverse psoriasis is the second most common type, accounts for 22.2% of cases in infants with psoriasis. Causes lesions in the skin folds, in the armpits and groins, more often than adults, and in the anogenital area because of particular rubbing. You can see here this boy with psoriasis on his neck and axilla. And it's also very important to state how we see that this boy is obese. So the comorbidities in psoriasis do start since childhood. So it is important fact to state. Now, arthrodermic psoriasis, you can see this little boy here, very rare in children, but potentially life-threatening, characterized by erythema covering more than 90% of the body surface area, as well as scales. This one doesn't have a lot of scales, but it's mostly erythema. So a differential diagnosis will be seborrheic dermatitis. Pustular psoriasis occurs in 1% to 5.4% of children with psoriasis, more common in adults than in children, characterized by localized or systemic superficial septic pustules. Acute generalized pustular psoriasis and annular pustular psoriasis frequently occur in childhood. So they're important diseases to think of when looking at a child. Other forms, as we have stated before, pustular and erosive, it's severe in 1% of children, can occur in the first week of life, more common in children than adults. GPP, annular type, in 60% of patients. They have been associated with deficiency of IL-36 as in Ditri, and palmoplantar pustular psoriasis also can affect the neck. Pustules tend to be multifocal and also can be associated with other defects like in the IL-1 receptor, when we have to think of pustular psoriasis lesions associated with osteomyelitis. DIRA deficiency of IL-1 receptor antagonist can include joint swelling, pain, oral stomatitis, and pyoderma gangrenosum, most born prematurely. So those are important differential diagnosis of pustular psoriasis during childhood. Now, juvenile psoriatic arthritis, it occurs mostly in 1 to 10% of children with psoriasis. The peak age of onset is 9 to 12 years. Symptoms include swollen joints, sensation of pressure, pain when moving, feeling feverish, and motor impairment. So those are important things to consider when you have child with joint pain and psoriasis. Comorbidities, again, should be emphasized because we need to start early before they turn into adults that are more difficult to change in their habits. So obesity and overweight should be addressed. And we normally do yearly monitoring starting at 2 years of age. We measure body mass index and their percentiles. We should check for diabetes in the family and also in the children, hyperlipidemia, hypertension, and non-alcoholic fatty liver disease. Arthritis, we also tend to do ask for joint pain in the children and any difficulties in walking or moving around. And also inflammatory bowel disease is also important in our children. So we discuss with our gastroenterology pediatric specialist to check them out, see if there's any symptoms for these diseases. And psychiatric issues are very important because it affects not only the children, but the whole family. So these are important considerations when we're treating pediatric patients with psoriasis. Topical treatments, we have emollients, topical steroids. We also have vitamin D derived medications. The tacrolimus and pimecrolimus are used especially for flexural areas. That's our routine. We don't have access to our country, so I have no experience with that. tar is a mainstream of our treatment for scalp psoriasis. We have a shampoo here in Costa Rica we use very often, and if it's considered a bit strong for the baby's skin, we diluted 1 in 4 parts of water, and that helps in a lot. Anthraline, we don't have access to that, and salicylic acid, we don't use it much. We consider it sometimes it could be a little bit irritant, and also depending on the surface area, we have to avoid salicylic, so try to avoid that medication. There's newer treatments here that can be or are being approved in our population of patients. But again, as we can see, there's a difference between European approval status and FDA approval status. So again, we use them, but they're not officially approved. They were grandfathered in. There's the studies now being conducted to evaluate the efficacy and safety of certain medications, such as the IL-23 inhibitors in pediatric patients with chronic plaque psoriasis. Also, we have these other medications, which are also IL-23 inhibitors, and we're waiting anxiously for their approval so we can have very effective treatments for our patients. Here are again the biologics, adalimumab, etanercept, ustekinumab, secukinumab, and ixekizumab are also approved. We don't have ixekizumab in Costa Rica yet, but we're waiting for them. And here are the dosages for the medications. So for take-home messages, childhood psoriasis is an immune-mediated inflammatory disease with a strong genetic predisposition. The natural history and course are unpredictable. All children with psoriasis should be screened for comorbidities. I do emphasize on that because if we treat early on and we control the comorbidities, the disease tends to be less worse. The current treatment strategy for children and adults with psoriasis is almost the same. We have not changed a lot. And in our countries, the access to more efficient medications is very difficult. The emotional development of pediatric patients and the effects of psoriasis on the patient's appearance should also be considered. Treatment options for psoriasis in children and adolescents are almost off-label, with little available data on the efficacy and safety. Management of this disease requires multidisciplinary approach along with appropriate proactive therapy for long-term remissions. So we use proactive systemic treatment and proactive topical treatment, as it has been done in atopic dermatitis, for example. Dermatologists play an essential role in treating children with psoriasis and managing their symptoms, but they must work in collaboration with primary care physicians and other specialists as required. So thank you very much for your attention, and this is my email if you have any questions.